Hi, my name is Nathan Blaseg. I am a medical student at the University of South Dakota Sanford School of Medicine, and I'll be presenting today on a simulation-based interprofessional ICU bedside rounding course that we developed for medical students and other health profession students alongside Dr. Kozmenko, who's my faculty advisor. So a little bit of background, the entire point of this course was to lead to improved outcomes for patients, and there have been several studies that have shown that interdisciplinary rounds, that is, rounds involving physicians, pharmacists, different therapists, these things improve outcomes for patients. And these look like, decreased length of stay, increased safety, and increased satisfaction among staff also. However, there have been several barriers that have been identified that have been in the way of implementing successful interdisciplinary rounds. And these are things like a lack of a clear structure and a need for role clarity among these team members. And these barriers are part of the reason why we developed this program, because we thought that early intervention could lead to improved future healthcare teams by teaching students early on about interdisciplinary rounds and interdisciplinary teams. And this is being done in an ICU setting, so multidisciplinary teams are essential in ICU due to these high complexity patients. And this is an area where simulation could be really beneficial because many students don't get a lot of experience in the ICU. This is a very high intensity, low capacity environment, and it's a great way to learn in-depth medicine and in-depth teamwork. And overall, the goal of this course was following the WHO definition of interprofessional education, where we wanted 2 or more professions to learn with, from, and about each other to improve collaboration and the quality of care. And that was really the overarching objective of this course. Now, the programs we involved here at the University of South Dakota Sanford School of Medicine, we involved medical students. We involved the nursing program here, the physical therapy program, occupational therapy, respiratory therapy, as well as a different university, South Dakota State University's College of Nursing and College of Pharmacy. Now, we used feedback from instructors from all of these programs to build the curriculum and the simulation experience, including our virtual electronic health record, which we'll discuss next. And the course designers used experiential learning in the form of guided discovery as the main teaching method. And we hypothesized that participants would be able to identify each specialty's role in this ICU bedside rounding environment and establish productive communication channels amongst their team members, allowing for them to kind of best address the patient's needs. So we really allowed students to explore the different roles of the team members and explore the electronic health record, and then interact in a team environment with very little actual teaching and involvement from the faculty. It just let the students communicate and involve with each other. So we can take a quick look at our virtual ICU electronic health record that we developed in-house here. So as you can see, we have different patients, all with different conditions. We'll look at one example here. You can kind of get a quick dashboard that has everything from medications to vital signs, and then you can also look at different notes from different specialties. So you might look at the admission note, and then you can look at the notes for all the different specialties, including physicians or nursing across all the different days of the stay. So this was a 10-day hospital stay. We have physician notes for each day, just like you would have in the hospital. Now, this program also includes diagnostics like imaging or EKG on all the different days that you can view, all the way down to viewing the actual image. And again, this was all built in-house, and this is what the students use before the rounding to kind of look at the patient, do pre-rounding, and that way they can show up and they can all contribute and be up to date, and then they can discuss the assessment and plan of the patient. So a little bit about how this simulated rounding works. So participants were split into 2 teams, and each team contained 1 medical student, 1 to 2 nursing students, and 1 to 2 pharmacy students, as well as these other therapy students as they were available. They were briefed for 15 minutes about kind of the rules and the expectations of the simulation activity beforehand. Now, medical students were acting as PGY1 interns, and they would summarize the patient's 10-day course in the ICU, and then they would provide their assessment and plan for further care. They would consult the other members of the team as they saw appropriate, and this would allow us to analyze how well the students worked within a team and how well they understood the roles of the other team members. Now, this was a hybrid simulation methodology. This was done in our simulation center using both a standardized patient and a high-fidelity simulator. We used the Laerdal SimMan, and so the vital signs were displayed on a monitor, and they were able to do interventions. However, there was a standardized patient lying there in the bed that they were able to talk to. Now, during this rounding, the faculty assessed the medical student performance, and we'll talk about the assessment, the assessments that we use coming up, and the encounters usually lasted about 30 to 40 minutes overall. Following this rounding, they underwent a debriefing and some assessments. Now, in this debriefing, the participants graded both themselves and their teammates using an electronic interprofessional education assessment rubric that we developed. During this debriefing, they also discussed what they had learned about the role of the other professions and how their input affected the care of the patient. They also had a good opportunity to educate each other on their different professions and kind of their specialty-specific protocols. So, for example, nursing might have a specific protocol about this medication or what to do when this happens with a patient that many medical students might not even be aware of. So the debriefing really allowed a great opportunity for students to intentionally teach each other. They had an experience during the rounding to kind of learn passively from each other by watching kind of how their role played out. But during the debriefing, they really got an opportunity to learn from each other very deliberately and to teach each other. So that was very beneficial. Now, looking at the assessment, we developed this assessment based on the IPEC core competencies, and this was a 9-item assessment that was completed both by, or altogether by the faculty, the standardized patient, and the peer participants evaluating each other. So they received a 0 if it needed improvement, a 1 if they got good, and a 2 for outstanding. So this looks at different competencies of interprofessional education, things like effective communication sharing, respectful communication, suggestions on improving team communication and things like that. So this was assessed, again, the faculty, the standardized patient, and the peers assessed each other using this assessment. And the medical student's grade in the end was based on the conglomeration of all of these assessments from the faculty, the standardized patient, and their peers. Now, secondly, the medical student faculty also used another assessment tool to assess clinical competencies of medical students. And so they would look at whether or not the medical student discussed things like consults or how long the patient has been in the ICU or whether, they were on a ventilator or something like that. And this was a way for us to assess both the communication and the IPE competencies of the students as well as the clinical competencies of the students. And so their grade would be a conglomerate of these things. Following this rounding, the students all completed a satisfaction survey. This was on a scale of 5 to 1, so 5 being they strongly agreed, 1 being they strongly disagreed. And so they would talk about things like whether it was realistic, well organized, if it enhanced their learning. And this was a great way for us to get feedback on how to improve the course as we did it, and just to see how the course was being received and how we might want to implement it in future healthcare education programs. So looking at some of our results here, you can see this is that 9-piece IPE competency scoring assessment. And you can kind of see some interesting things. So we used a student's one-tailed t-test to kind of characterize the differences between the faculty, the standardized patient, and the peer assessment scores. So between January and October of 2019, we had 269 students that participated, and this included 65 medical students. Again, they received a 0 if it needed improvement, a 1 if they received a score of good for that competency, and a 2 for outstanding. And then the mean is displayed there. Interestingly, there was a significant difference between the standardized patient grades and the faculty grades, and the standardized patient grades and the peer assessment grades. And we'll talk a little bit about why we might think that happened. There was no statistically significant difference between the faculty and the peer grades. But you can see overall, the students did quite well. They scored between a 1 and a 2 as a mean for no matter who was grading them, so they were scoring between a good and an outstanding, so we were quite happy with the results from that. Then we can look at a composite of both that IPE assessment and that clinical assessment, and this is all the faculty score. So the faculty completed that IPE assessment of the students and the clinical assessment, and then we displayed all that data here on this table. Again, they received a 0 for if it needed improvement, a 1 for good, and a 2 for outstanding. And you can see here on the different items of the 12-item clinical competency assessment, most students did quite well. There were a few that were missed often by students, and we'll discuss those kind of in the discussion. But all in all, students did quite well and really hit a lot of the clinical competencies that we wanted to see. In terms of that satisfaction survey, we were very happy to see that the average satisfaction score was 4.57. And this was, again, over 254 students that did this assessment, the satisfaction survey, and so it really was quite well received. Now, in all this analysis, we performed Cronbach alpha analysis on all of our data, and this ranged anywhere from 0.82 to 0.95. And that Cronbach alpha, that's just a measure of high internal consistency, so we were happy with our numbers there. Now, some interesting discussion points that came out of this data and how we can use it going forward. To date, this course has been really well received by the participants, and so we're looking to utilize it further in different programs. Almost half of the medical students failed to address the code status, and roughly 1/3 failed to discuss indwelling lines. So again, this comes from that clinical competency assessment that was done by the faculty members on the medical students. And this kind of helps us to identify where there might be some gaps in the students' education and where we can improve how they're viewing ICU patients and how they discuss them on rounds. Obviously, failing to address these things in the real world can lead to very real consequences such as increased nosocomial infections or legal ramifications. But it was great that we were able to make these mistakes in a simulation environment so that we can address them in the debriefing and talk about how we can improve those things in the future. Like I mentioned earlier, standardized patients gave significantly lower scores to medical students compared to the faculty and the other interprofessional team members grading the medical students. And this kind of brought up an interesting point that potentially this could be a difference in expectations that could be applied to real-world patients. So these standardized patients really could be viewing the medical students like real patients would view us in clinic, and that we need to keep in mind that our expectations from our patients may be higher than those placed on us by our peers and by our faculty members. And so that was kind of an interesting look into how standardized patients and how patients in the real world might view expectations of medical students. Now, most sessions had great, ample interaction between the team members, and the medical students did a great job of leading the team in an inclusive manner. However, there were a few sessions where medical students failed to engage their team members in the assessment and planning process. And this allowed great opportunity for teaching and for learning for all team members about how to effectively communicate in the real world, in a real world ICU experience. And this provided really useful ICU experience, like we said, because most students indicated that they had very little or no ICU experience prior to this simulation activity. Because it's such a high intensity, low capacity environment, it's not a place where many students get much experience before they're thrown out and practicing in the real world. So this was very beneficial for them to get experience in that realm. In the future, we would like to see inclusion of more specialties: physical therapy, occupational therapy, social work, respiratory therapy, and we're kind of exploring how we want to incorporate those. And that's going to present some difficulty, but I think it really would improve the experience and improve the realisticness of the experience and of the simulation. So in the future, we'll be looking to implement more specialties to make this a more inclusive process. Interestingly, these teams kind of naturally developed a flattened hierarchy team structure. So this is when no one individual had a higher standing. It's not that the medical student had a higher standing than anyone else, but they led the team and they kept the communication lines open. They allowed other team members to contribute. And this can help, in the future, these students seeing this flattened hierarchy team structure can help change future hierarchical structures in medicine. So traditionally, we have this kind of traditional hierarchy where physicians are sometimes, above their peers and their colleagues in other specialties, and this can lead to breakdowns in communication and breakdowns in teamwork. But in the future, we're hoping that this flattened hierarchy team structure and implementing this in an educational way can lead to giving other professions the capacity and the confidence to share their insights in the real-world setting, and allowing medical students to learn how to enable their team members to share confidently, because they have a lot of really useful insights. And that was something that a lot of medical students learned throughout this, is that their team members have invaluable insights that they can share about the patient and about patient care, and learning how to enable their team members to share those insights was a really beneficial thing. So our conclusions here, we found that this simulation-based ICU bedside rounding course was an effective method of exposing students to a high-intensity clinical environment where teamwork is key. Again, these are very high-complexity patients where teamwork is often utilized and necessary for patient care and for the benefit of the patient. And we found that interprofessional education and simulation are effective teaching methods to achieve improved communication and role clarity in healthcare teams. Many of these students came out of this learning many things about team members that they'd never known before. Lots of medical students said things like, I never realized that nursing did this, or I never realized that pharmacy could help me with that. And so it was a great opportunity for medical students to learn about the roles of their other team members in this interprofessional environment and learn from the team members both passively, just by watching them, and actively by actually receiving teaching from the team members in that debriefing session. So we really thought that, in conclusion, this simulation-based interprofessional course implemented at this appropriate time in healthcare curriculums and utilizing these applied principles in effective teamwork and communication, this can lead to health profession students being better prepared to work in this dynamic interprofessional healthcare environment. And that is all I have. Here are my references for those interested. Thanks for following along with this presentation.